Good afternoon and welcome to the Australian Centre for Value-Based Healthcare webinar, Reaching Out, Reaching In, hosted in collaboration with Wild Health. I'm Kylie Woolcock, Chief Executive at the Australian Healthcare and Hospitals Association. Before we get underway, I would like to acknowledge and pay respects to the traditional owners of the many lands on which we meet and recognise their continuing connection to land, water and culture. I'm currently in Canberra on the land of the Ngunnawal people and pay my respects to their elders past, present and emerging. Today, we're running our webinar a little differently. We have Jeremy Nibbs, the publisher of The Medical Republic, and Wild Health, who will facilitate a conversation with some special guests about creating a roadmap to a connected health system, something that will be explored with a broad range of stakeholders at the upcoming summit on the 18th of October in Melbourne. Please feel free to ask questions as they occur to you via the Q&A function you'll find at the bottom of your screen. But right now, I'll hand over to Jeremy.
Thanks, Kylie. Hi, everyone, and welcome to today's webinar. Your panel of experts today includes Tracy Johnson, who's CEO of Inala Primary Care and Director of Cubico and a member of the Australian Institute of Health and Welfare Primary Healthcare Advisory Committee. Kylie, who's introduced herself. Dr. Paresh Dauda, Director and Principal at Presentia Health and Next Practice, plus many other roles in developing government policy. And David Rowlands, who's a long-term digital health expert and consultant, a director of Wentworth PHN, and author of a recent, or not so recent, seminal report on technology and standards in healthcare entitled A Health Interoperability Standards Development, Maintenance and Management Model for Australia, which we'll get to in terms of relevance. As Kylie sort of suggested, the webinar is about an hour long and you can ask questions. We'll try and answer the questions directly and we might interject to ask live. And if we can't get to those questions, we'll get to them later. The session will be recorded and should be available on Wildwood Health and the AWHA website after today if you miss anything or you want any peers to see the session. So what's needed to extend and connect outcomes-based programs within hospitals effectively specifically into the primary care community and perhaps even into the aged care community? Kylie, just to get us started, can you give us a quick value-based care for the tertiary sector 101, including what is currently in play and what is more of a wish list for your group in the future?
Yeah, thanks, Jeremy. So I guess simply, value is created from the improvement in health outcomes for the costs of achieving those outcomes. And while it sounds like a nice, simple equation, it isn't necessarily straightforward. Often there are a number of factors that come into play. First, you really need to identify a group of people with shared needs, then look at their full care pathway, not just individual experiences of healthcare in isolation. We're engaging with people to understand the outcomes that matter to them and measuring those. And we're very good at measuring activity, but outcomes is something that requires a great shift. Then where it's about having integrated teams come together to understand that pathway and how it contributes to improving outcomes and designing care to improve those outcomes for the costs. For Australia, our healthcare was really set up to provide acute care, and there have been some significant changes to the health conditions that people manage, as well as in the way that care can be delivered. So the reform that we need requires the many parts of our system to shift together towards a system that is value-based. I think we'll find that some clinical areas and services will lend themselves to doing this more easily than others. But there are some key enablers that we at AWHA think about that will help everyone shift. And we tend to look at those through 4 lenses. The first being the governance, the second being data and performance information, the third, the workforce, and the fourth, funding models. So from a governance perspective, it's really the National Health Reform Agreement that really sets that scene for how this shift occurs. And in 2020, the 2020 to 2025 agreement, there were lots of positive signs in that to support that shift. One of those that I will highlight is the joint planning and funding at a local level. This is really that governance structure for the hospital system and PHNs to work together in designing care pathways around people and communities and not around services or providers. And I'm sure we'll talk about that more. From a data perspective, the focus, most of our focus on data has been around population level analysis. And so while the technology exists to allow us to follow people through the healthcare system, to garner insights and inform decision-making in real time, we're really not leveraging this enough, and that's partly due to challenges with interoperability. The third one I mentioned was that workforce perspective. How do we create that authorising environment to provide care differently? This includes how we support our workforce to use technology. I think we've really got to look at different, not being promoted as second rate. We need to look at the evidence for different models of care and put in place some really strong clinical governance frameworks to ensure safety and quality in real time. And technology will help to provide that support. We're going to see a lot of challenges of professional identities, of power, of incomes. So we really need the whole system to be working together on that shift. And the final one, I guess that lens I mentioned, was the funding models. It's only one enabler, but it is a powerful motivator. So how do we shift a system that's heavily dependent on activity-based funding and fee-for-service models to shift to ones that incentivise volume over value? And we do know that the independent, or the newly named Independent Health and Aged Care Pricing Authority has certainly opened up some opportunities in that space, which is great, to do the shadow pricing of alternate funding models like bundle and capitation payments. But we still need to be thinking about, well, what are we measuring if we're not measuring activity in that particular space as we do the shift? So they're probably the 4 areas that we really want to see some shift in our system together.
So I guess the question is that the 2 big elephants in those 4 objectives are in the room on those 4 objectives would be, and you said it, you've said it, we want to look at funding. So one, to what extent is all this work constrained by the current funding paradigm for hospitals, which is still fairly activity based? That's the first question. The second is the idea that hospitals are seamless outwards to the community is an idea still. How important to achieving outcomes-based care from the tertiary side is making much better progress in connecting to the community, especially GP networks via PHNs or whatever. How important is that to achieving all of this? And practically, just, I know there's a lot of questions here, Kylie, but what are some even baby steps we need to take fairly quickly given the current environment?
Yeah, look, I think funding models, it's one enabler, but we can't continue to just blame everything on funding, because there are a lot of elements that sit around that for this shift to happen. I think there's a lot that we can do in terms of data-driven improvements. And really, it's important to understand the data before we start linking funding to it. We need clinicians and services to understand, the shifts in risk that come with certain different funding models. But we really need to be open in talking about what those shifts in risk are and what the pros and cons of different approaches are, and enable people to shift together, I think is critical.
How do you understand the data of your patients who are sitting out in the community in the context of what you're trying to achieve in the hospital sector, given that there's quite a big disconnect at the moment?
Look, I'd be happy to throw to other people in the group to respond to that one. But I mean, we do see, I guess, a lot of data linkage happening. But again, it's sort of after the event rather than in person, or there's sort of band-aid solutions, I guess, being put in place simply because we don't have systems that connect up.
Okay, well, I'll take it as a segue and move to Tracy. Tracy, you're in general practice. You've been across the whole system. All parts of the system, and so you have a good sort of a helicopter view. Do you think general practice is stranded on a bit of a legacy technology desert island in terms of trying to connect to hospitals? So is there something that we're missing here that the federal government needs to do about the general practice sector? Because they at the moment they seem they're very hard to organise, because it's a sort of a herd of cats of small businesses, and their technology's bad, and no one seems to be able to herd that, including the colleges, the major GP colleges. Can you give us a sense of what you think there?
So to extend your analogy, I absolutely think that general practice has been left as an island. What it would be nice to think of, to use the analogy more broadly, is if we were all like Fiji. Fiji is a cluster of lots of little islands. They're all pretty casual and, comfortable dealing with each other because it's a nice, friendly place. Whereas I think what healthcare has become in Australia is the dominant island, Terra Australis, which is the hospital system. In recent years, I think there have been significant changes in disability and aged care. So they're a bit more like Tasmania. They've kind of got their own momentum and scale and things like that. And general practice, which once would have felt a bit more like Tasmania, has become much more like Fraser Island, which is the world's largest sand island, a place that everyone must visit before they die here in Queensland. And I think what we've found is that there's been this sense of, like a sand island, the wind blows around and the sand moves and it's inherently unstable. And that for me is what general practice feels like, which then leads on to the second question. Are we a desert island technology-wise? I think the legacy systems that general practice are using, largely because our funding model recognises clinical things happen in a general practice, but has never really recognised that general practice is a business and we rely on it to be a business. So the money that's left over after we pay our clinicians, and there's growing evidence that there are doctors in general practice saying, well, my specialty cousins earn all of this money, so why shouldn't I get 75% because my income's been eroded so much? So on 25% of what's left over, how do you fund a decent digital platform? How do you understand all of the different options that are now out there as plugins and patient improvement and engagement tools and all of those things that in other parts of the world are being embraced, whereas we have such an incredibly thin management and administration capacity in general practice because it's not recognised as important. If it's not important, how do you get change? Because there's no one there to map the digital opportunity and the patient opportunity and the clinical interactions and the privacy and confidentiality and business things. So there's no change infrastructure in general practice either, whereas at least in the hospital system, they've got quite large administrative capacity, increasingly in the aged and disability sectors as well. So they're much better at going, actually, we need to get rid of this very old system and go cloud-based and do this and do that. What do I think the government could do to drive that? Well, clearly they need to acknowledge primary care is important and fund us differently. They need to understand that change needs to be invested in. And finally, we actually need some standards. In general practice, there have been so many systems just emerged to respond to the problems in workflow and patient interaction and business practice that exist in primary care, that there's been this flowering of many flowers in many fields that have come up, but there's no standards tying any of them together. So the government needs to get bold and actually just come out with some standards. They might not be the world's most perfect standards, but at least if we have standards, it actually means we know what we're interoperating with and we can scale up and we can get sensible. Whereas at the moment, in an unregulated, unsystematized environment, everyone does their own thing, nothing talks to each other, and we all get trapped in an isolated island that gets more isolated as we invest more in that particular part of the island.
I might just jump to David because David's quite a standards expert here and get you to explain a little bit more how that could happen and what that might do, because it feels like if you're going to bring in standards, that's standards for everyone. That's hospitals, that's general practice, that's the whole deal. What does that look like, David? And I have a sense, and I think you have a sense, that the government actually really wants to do this. So can you maybe talk to that just quickly?
I can, but I would first like to say there's a danger of asking the wrong questions here.
Yep.
And if I can just explain what I mean by that, I'd like to go back to where Kylie started with the 4 priorities of governance, data, workforce and funding. Now, what data you want, what workforce you want, and how you're going to use your funding are all dependent on what you actually want to do. And that's the real elephant in the room here, because we have a health system in Australia that does beautifully what it is designed to do.
Yes.
It does it really beautifully. It delivers unintegrated care because that's what it's designed to do. And that's what the funding part of it and the workforce part of it and all those other parts do. And the business design of our healthcare system is designed as an ill health treatment system, not as a health and well-being system. So before we should talk about the data and the workforce and the funding and get down to things like standards, I think we've got to have this national discussion, and that's ultimately why we're having this discussion here today, about what we want the system to be. Because I think there's a lot of us now saying we don't want to, we don't want to continue down the same road. We want to change direction somewhere. So,
can I interrupt you for a sec?
yeah,
So
sure.
I think what you're saying makes a lot of sense. Like, what are we doing here before we start? Because at the moment, there's a lot of government action and activity, and there's a lot of intent, and there's a new government with optimism, and they want to change things. But there's a lot of lobby groups hitting them up in separate silos. And I think what you're suggesting, David, but you can go here, is something, a national health summit, reform summit along the lines of the job summit. Is that what you think?
It could be something like that. There's lots of ways to skin this cat. I mean, what
are some other ways?
All the Labor government did, for example, was get David Gonski to come in and do an education review. And actually, he gave some pretty sensible answers. No one's done anything with them. David Thodey came in and did a public service review. He did a pretty damn good job. It's just that no one's implemented it. So there could be an expert review by someone highly credible in the business world, for example, or it could be a national health ambitions summit where we don't get bogged down in the detail of how hard it is, but we actually just design what it is we want to achieve and then let a bunch of experts work out how to do it. I think there's many ways to do this, but what I am saying, and AHA has had plenty of goes at doing it. Not so long ago, they brought out a health system reform paper. That was a pretty good paper, but we've got to get past the different groups writing papers and different groups all coming at it individually. We've got to have this national debate about what on earth do we actually want to achieve before we go burrowing down the rabbit holes of how are we going to achieve it. I'm still happy to answer your question on standards, by the way.
We can. I think
get
we
this
can,
other stuff out of the way.
I think what you've said is a really absolutely important to do. But I'm going to sort of hold you to the idea, because I look at it and I go, there are a lot of papers and there are a lot of there's a sort of a lot of co-alignment starting to happen in terms of what people want. There's no one who doesn't think that we have a chronic care crisis emerging and that we're not set up. The system isn't set up to do it. And I think even if you go into a lot of the federal government papers on the topic, there's a lot of acknowledgement about what they want to do. What's the mechanism by which that alignment starts to happen with like it feels to me like it's an easy thing to set up a purpose of what we're trying to achieve and then come down from there. But what's the mechanism? It's a federal mechanism with all the states around the table, isn't it?
It's not an easy thing. It's like what we stress in the health sector about people wanting to change behaviours. It's like the alcoholic. You've got to own the problem before you can start to fix the problem. And step one is for us in the health sector to collectively say, we are doing what we have designed the system to do. We have to own that. We have to take responsibility for it. Yeah. And then we've got to say, but now we all are starting to agree that we have to change it. Yeah, until we actually own the problem, we're not going to get past the writing papers stage. If we then have that process where we collectively take responsibility for the problem, then we need to build that consensus about a health and well-being system, for example, because we've got a huge investment, as Tracy said, people's incomes, people's livelihoods, whole industry subsectors that are built around the business of ill health. The health and wellness stuff is actually being developed outside our health system. It's by other players. It's by the people who sell us, smart watches and who run gyms and things like that. There's this whole other industry that's not health that we need to say, well, where on the spectrum do we actually want our sector to be? What kind of sector do we want it to be?
Okay, I'm
We
going
can
to
only do that with a real national debate.
Yeah, I'm going to swap to you, Paresh, and put you on the spot. To me, that looks like you need someone to be pulling that trigger at a high level. Who do you think would be pulling that trigger, Paresh? And how? Because if there's ever a time we can sit back and do it, it's probably now. New government, optimistic government, energetic government, Labor government probably happier to fiddle with Medicare much more than a Liberal government ever was. Can you give us a sense of what you think?
Yeah, sure. Thanks, Jerry. And look, I think, Kylie started the conversation telling us about value-based care and gave us an equation, and the numerator of that equation was outcomes. I guess the qualifying thing I'd put on that is outcomes that matter to patients and our community and our, the people we're caring for. So the reason I do that is because I think I bring it back to what David's talking about, and really what is it, what outcomes, what is the public value here? So what is the public valuing, and what outcomes are the public wanting out of health? And when I think about this, when I speak to my patients on a day-to-day basis, and I do a lot of older people's care, so a lot of patients I see have got chronic conditions, they've actually got multimorbidity, and quite a lot are thinking about end of life as well. When I talk to them about what matters to them, the conversations are, I don't want to be in pain, I want to be independent, I want to be able to move around, I want to be able to receive care that's respectful and involves me. They don't talk about my diabetes needing to be controlled to the next level, or my blood pressure needing to be controlled to a Y level. So I think if that's the public value, like if that's what we're striving to achieve, the solution is got to be cross-sectorial. It doesn't just the problem, we see the problem in health, but the solution to the problem doesn't necessarily all lie in health. It's got to be cross-sectorial. So come back to my response to your question, where do I see this happening and who's responsible? I actually think it's multiple parties that are responsible, multiple departments, both at state and federal level, that have accountability and responsibility for this. And I think what we almost need is to understand that, appreciate that, acknowledge that what public value we're trying to seek, and then actually get a coalition of the relevant key sectors together to work in this and on this in a very integrated way. I think when we talk about integrated care in Australia, we tend to talk mostly about health. We tend to talk about primary, secondary, tertiary.
Yep.
When other countries talk about integrated care, they talk about health and social.
Social, yeah.
So I think we need to actually have a much broader conversation. I think health's very critical in that, because health sees a lot of the issues that arise as a result of lack of integration, which is cross-sectorial deficiency, not just deficiencies within health.
Yeah.
So sorry, I think I might have increased our problem tenfold.
Yeah, so I'm just going to hassle you guys to get you to a practical step that might happen. I'm going to put you on the spot, Tracy, because you're pretty good at this and you don't care. If you had a very high up person in the Department of Health or the government listening to this, it feels like it's something that has to be coordinated at the minister level and the federal Department of Health level at the beginning. Well, what would you suggest they might think about that's practical, short term? And I've just written here what you said, Paresh, which I think is a really good coalition of the relevant. To put a coalition of the relevant into a room, you might even just start with one day and say, what have we got here? What's possible? And then after this, I'm going to ask you what might be possible if you had that room. But how do you think that might? Who could do that, Tracy?
Look, I think, the big bucks clearly sit in Canberra. And I think in Canberra, just like in healthcare, everybody has their silos and power plays. So, we have a department looking at disability, another department looking at health, another department looking at aged care, another department looking at all many things, and they've all got new ministers. So they're all jostling for their share of the Treasury pie. To cut through that, I just think, the notion of health and prevention needs to become our ever increasing conversation. The government launched a preventative health strategy in December of last year with effectively no funding behind it, but they acknowledged that there was a problem. We have patients turning up for things that should have been dealt with years ago and that could have been prevented. If we start asking the question, how are we trying to reduce demand on our healthcare system, which at the moment it's a system that's collapsing with demand. So how do we reduce demand on our healthcare system? Well, it does need to get back to the social determinants of health and what matters to patients and what role the housing sector and a whole bunch of other sectors can play in all of that. So, if we really focused first, well, not only, but one of the things that we need to focus on is how do we get funding for prevention? Well, that preventative health strategy needs to be funded. We also need to be responsive to patients and what matters to them. So the notion of, instead of activity-based funding, which for me means nobody is monitoring return to hospital rates in this country. This is the most extraordinary thing. Every other country monitors rate of return after discharge to hospitals, and then they start working backwards through the system and saying, how do we stop that patient representing? And then the bigger question, how do we stop them presenting in the first place? If we started doing more of that and then having bundles of payment that can be shared across the system, maybe the reason that patient's presenting to hospital is because they're living in a mouldy house in Queensland that's had floods and rains and whatever for the last 3 years. So as a consequence, their respiratory health and a whole range of other things are shot to pieces. Well, go in and sort out the mold in the house. This is what New Zealand and America and other systems have started doing, because that notion of how do we stop demand on the healthcare system is what they're more focused on than how do I make sure that I manage my waiting list so that it doesn't look so bad for me that I'm not managing my demand. They actually go in and manage the demand by doing the right thing by the right people at the right time. And that might not be a health system answer, but the only way to enable it is by giving local people, local regions, local providers, those bundles of payment that are more flexibly allocated than I'm going to pay for a knee replacement, I'm going to pay for an emergency department admission, I'm going to pay for a level C consult at a general practice, because that might not be what the patient needs. And we need that flexibility as intelligent adults to work together. And the only instrument we have for that at the moment is activity-based funding, which gets productivity, but not about the right sorts of things that we should be productive about.
Okay, back to you, David. Absent of someone actually doing this in the short term and getting a conversation and a coalition of the willing, because it does seem like a very big political thing to achieve, and maybe it's just not high enough in the overall agenda of the current government. And when you talk stuff like this at Big Bang, and there's so many people employed by government, like you say, in an ill health system, not in a health system, it scares a lot of people. Do you think there's any practical things that can be done absent of this that will move the system? And I'm talking about things like, do you see a possibility that an LHD and a PHN might merge in a region, and we might pilot what that looks like? And then you've got you've literally got Australia and Fiji merging, and then Australia's got to treat Fiji fairly, because Fiji's, in your analogy, Tracy, Fiji's actually a secret to the future of this system. So that one, I'll ask you that one. Do you see a world where we might trial a regional health system which isn't too threatening to everyone, and we can all sit back and look at it and see what happens?
Well, I think that's very threatening to a lot of people, but I think we have to try something different. I do think there are things we can do practically to get that earlier agenda on the table. But as Paresh has said, the problem with outcomes, if we actually want to get a focus on outcomes, which we need to, the problem with an outcome is that no individual piece of the sector can deliver it. And if you can't actually deliver the whole thing, then you don't want to be held accountable for it, because then you're setting everybody up to fail. So the only way you can have an accountability for outcomes is if the entity that is responsible for the outcome has the wherewithal to produce it, which means it has to be an aggregation of the primary care system, the secondary care system, the public health system, the social care system. It has to feature all of the elements that actually contribute. So we have to come up with a system design. I can't see any other way for getting accountability for outcomes than to merge the governance of the various parties that contribute our total health system. And we can do that, I think it does make sense to do it on a regional basis, because the needs in one region are different to the needs in another. Rural and urban are a classically obvious example of that, but there's lots of other differences as well. So I think we have to do something different, and I think experimentation is good. We are getting co-commissioning happening in a couple of places in New South Wales, where the PHN and the LHD are working together to try and come up with some more sensible ways of doing things. But it is wading through treacle.
Yes.
Because it's getting two organisations or two sets of organisations with two quite different sets of accountabilities to somewhere meet at the margins. We're not going to make the big difference until we stop focusing on the margins and start focusing on the main thing. So I think, sorry, that's a long-winded way of saying, yeah, I think we need to try some different organisational forms. That's going to be extremely threatening. It won't be low threatening, but I just don't see, I think we're at this fork of the road where there isn't a baby steps solution that's actually going to take us to integrated care. I think the baby steps will I think they're an excuse for not going where we want to go.
Yeah, you work with Wentworth, which is and Western LHD, I think, which are
Western Sydney LHD is
Western
the LHD,
Sydney.
and
which
provides the Western Sydney.
Yeah. And when you step back, I mean, there's a lot of good relationships in various regions between PHNs and LHDs, but that's a particularly close one. And one where it feels, when you say it's going to threaten a lot of people, it surely will, because the whole thing is the opposite of what we do now. So everyone's got a job and they do the job based on something that you're not going to do in 10 years' time. So you have to start slicing it up at some point. It doesn't feel to me, now I've actually got no clue from the outside, so I'll give you a sense. It feels to me that when you talk to people both in a LHD and a PHN, more in a PHN, that in some of them there's a real will to try and merge. And I think that merge is probably, like you say, not the only thing you need to merge in an experiment. But given that, I know I'm pushing this idea, but do you think that that's if you get to a willing PHN and a willing LHD, and maybe it's a couple of willing other regional organisations in one area of Australia, enough to pull the trigger, do you think that could be done? Maybe I should ask this question to, well, you go quickly and then I'll ask Kylie from the hospital.
I'll go quickly. And I won't speak for Wentworth because we haven't discussed anything like this as a board. So, but I'll speak more generally.
You seriously have
PHNs have been established to change the way primary healthcare happens.
Yeah.
Through supporting the primary healthcare sector to change itself. But their fundamental reason for being is transformation. The LHDs are basically there to deliver business as usual. So, that's why we're meeting at the margins. It's why we're not meeting head on. They are different beasts. But as I said earlier, I do think they have to, I think we have to get far more aggressive than we actually are.
Yeah,
I'll stop there.
yeah,
And a
Kylie,
bit controversial at that point, Jeremy.
yeah, go for it.
Another analogy. So if we go back to healthcare more than 100 years ago, hospitals, you know, were unusual things. Most care actually occurred in the community. And then we invented all of these magic machines that go bing, that need super specialist people to know how to make them go bing. And so we created this hospital system, right? That was the evolution. Technology actually drove the aggregation of care into bigger care centres, because big, expensive technology machinery required volume and it required specialty around it. We've now got chronicity as our main problem. Chronicity is a generalist thing, and we've got more and more technology that's the size of a toaster or your watch or whatever. So primary care is in fact where the system should be. That's about where people want it to be. It's the cheapest place for it to be. So I absolutely agree that we need to have some experiments about how do we merge hospital and primary care and PHNs and everything together. But what I've seen overseas that I think is a lesson to learn is that when you just simply merge the existing stuff and say, well, we'll put the hospital budget with the primary care budget is always such a tiny component. So you end up with the pimple on a pumpkin problem and all of the power dimensions that go with that. Whereas if we redefine what is the care that we need to deliver, there's so much stuff that happens in the hospital system, but it's become hospitalised and specialised and whatever. In fact, it needs to be generalised and primary care oriented so that there's more of an equalisation of where the money is and what the thinking is about how stuff's delivered. And then all of a sudden you don't end up with some of the problems that New Zealand and Canada and other places have had, where you've still got this tension between tertiary and primary. And that would be my plea. Let's experiment, but let's not just aggregate budgets and say we'll do the same stuff we've always done. We actually need to completely get everyone to reframe what business they're in so that you still don't perpetuate that same behaviour. And as I said, the pimple on the pumpkin will always win.
Yeah, Kylie, if you step back from, I mean, when we're in our pre-webinar Zoom chat, everyone was talking about how culturally, you know, the system does work well, but the system is historical and it's hugely hospital centric. Do you think we could set up some sort of trial where and I think what you're saying, Tracy, and maybe you too, David, is no, you can't just push a PHN into a LHD, that'll never work, which sounds sensible. You need to step back and go, okay, what do we need to make this work in this region? Is that possible, Kylie? Is someone listening in the Department of Health who might be able to put that together? And I think I'm asking you because there's a lot vested in the power of hospitals and what they do. And hospitals are hugely political too, in the sense that you build a big shiny new hospital on the Gold Coast, you're going to help yourself win an election. So
yeah, I think there are a couple of things in all that. I would echo the what has been said already, that we need to be clear what it is that we want health to look like and how we provide that, and starting with a blank slate, not trying to shift what's already there, is a really important place to start. I think we have to be careful about just piloting things because it's really hard to engage. I mean, you know, the health workforce is 1.8 million people. So when you start to shift, and I think it was the Productivity Commission in their interim report last month that specified actually innovation is difficult in health because it relies on diffusing ideas and adapting business models. So we need to recognise that you can't just go in with a 2-year pilot and expect someone to invest in changing a business model when after 2 years it's just going to all end. So it has to be seen as more of an iterative process that we're all shifting towards something, and that we may not, you know, at the end of 2 years, we're not throwing out the project that was, you know, implemented. It's okay, let's continually, you know, evaluate how we're moving towards that you know, that goal that we're moving towards. And I think one of the, you know, I reflect on some of the work that was done a couple of years ago to start developing a national health information strategy. AIHW was leading that, and then it stopped when with the pandemic and national cabinet being introduced, and it hasn't been restated. But I think that's a really important place to sort of pick up work, to sort of say, well, you know, what do we want out of health and healthcare? And then what are we going to measure that's actually meaningful about how we're getting there? But it's not about the activity. And then then design, I guess, the system that will allow us to achieve that, which will be, what are the governance structures? What are the, that will best achieve that, because there are so many parts to this system.
That sort of comes back to David in the sense that of what David was saying, because I think it feels like wherever you move in terms of trying to shift something here and create some meaningful step towards changing. First of all, David, I totally accept the point, what do we actually want? I'm making a comment now, but I don't feel like that's going to be a very hard thing for people at a very high level to establish, which is you want patients to have a better experience, and you don't want the system to go bankrupt at its highest level. And I think if you look at it now, what you're looking at is patients have an okay but degrading experience, and we are going to go bankrupt. But we feel like we're all talking here, and there's no, I feel like we're all still slow boiling frogs, because who steps up and creates that change or that catalyst for change? So I'm going to come back to you quickly, David, because maybe a pilot is impractical. That's my Labrador, everyone. I'll tell them to be quiet when I put David on. But maybe that change is practical. Maybe we're shifting back to an idea where we need to develop a plan that is long enough and has a good enough roadmap that isn't going to threaten so many people in the system. But we come back to that thing of putting everyone in the room. David?
Yeah, okay. Again, I'm going to come back to right where Kylie started, and Kylie said governance starts with the National Health Reform Agreement. Completely agree. That's a suitable vehicle for governance, because it actually is a place where you can set out what you want to do. And it links to some of the important mechanisms like dollar flow for doing it. At the moment, our Federal Health Minister, and I have to say, I met Mark Butler a number of years ago now when he was in quite a different role. I think he's a smart guy. I think he actually wants to make a difference. And he's put in place a strengthening Medicare task force. That will give us, I think, some of the answers. But that's a healthcare industry looking out perspective. I think we need to counterbalance that with an outside looking in perspective, where we really bring that consumer focus to bear, and where we get some business design, some industry design experts to take a look at health and to say, well, if this is what you want to do, then here are some of the mechanisms to do it. And I don't think you fill that with people from inside the health sector. I think you fill it with people from outside the health sector. So I think that's like a Thody or Gonski kind of review. I'm not suggesting those people, but that's what those reviews did. And I think if the Federal Health Minister had then in 6 or 12 months' time, both the strengthening Medicare task force findings and the outside in review findings, in there would be sufficient ammunition to find a way forward. So I just think there's a missing link in our national health system strategy development process at the moment. That's a purely personal view.
Yeah, so comment, I shouldn't comment, I'm going to end up like that guy on Q&A. The strengthening Medicare task force, like you say, it's a siloed task force. It's not going to address the sort of things you're saying, but some of the issues will sort of fall out of it. Without the outside looking in one with everyone there, well, I guess, yeah, without that, it doesn't feel like there's going to be any permission for anyone to start thinking and planning differently. And I'll ask you, Paresh, do you think if we could manage it, and in something like this, we're going to have, I imagine we're going to say we need everything in. And one of the things that looks very difficult is keeping aged care out of this whole problem, which so far it seems to be out of it. If we just, because I'm still going desperately for what might help move the system forward, if we just managed to do this at a federal level and had a statement of purpose and objectives, which were over 10 years, would that help everyone align and shift? I'm first going with you first, Paresh.
Yeah, look, I think, you know, that there's two ways, like one can approach this problem. One is big policy reform, restructure, etc. Pilots, trials. The problem is we've been doing that for the last 20 years, if not longer. You know, when you were talking earlier about LHDs and PHNs coming together, it made me think about the coordinated care trials, you know, back in the late 90s. But we didn't get anywhere with that. So you know, I think I echo what Kylie said, in that we need a direction of travel. We need a bit of a leap of faith that this is the way we need to be going. We then need to create some flexibility and agility in the system for organizations, in you know, in a structured way, but organizations who are, because ultimately, like when we're talking about integrated care and joining up care, from a patient's perspective, is where they experience it where the rubber hits the road. Like, you know, they're not going to experience it at a policy document level. It's actually at the microsystem level where they're experiencing it. And therefore, we need to enable those frontline clinicians to be able to get on and do rapid cycle change and innovation and put things into place, but create the learnings from that and look at scaling those when we get good learnings coming out. Now, certainly I think your kind of idea about, you know, at the MESA system, you bring the LHD and PHNs together, maybe, but if you're going to do that, you need to give them the delegated authority to be able to change some of the levers which are so preventative at the moment. So, you know, you need to be able to allow them to change regulation, a huge barrier for us working in a team-based care. So, you know, Kylie talked about you have care pathways across the full cycle of care, and then you have integrated care teams that deliver that full pathway of care. Well, the biggest barrier to that is regulation and workforce. You know, this morning I had to rewrite a radiology form because my nurse practitioner had done one yesterday and the imaging company wasn't accepting it because Medicare apparently doesn't allow this. Right, now that's ludicrous. She'd done a perfectly adequate assessment. She's working at her license level within her scope of practice, yet there's a regulatory barrier that's preventing her from operating at that top of license. We've got to get rid of this ludicrous regulatory barriers that prevent, you know, one of those levers, which is workforce, which Kylie talked about. I think the second thing we've got to do is we've got to let the local system really come up with the indicators that are going to make a difference, and we've got to create some integrated data collection systems. So again, it speaks to that lever Kylie was talking about, but we need to decentralize that and let the system, together with consumers, work out what those right indicators are, and then we aggregate upwards, rather than have a centralized approach where we push out the indicators and expect everyone to game the system, because I think that's what happens, right?
That is what happens now, yeah.
So, you know, let's decentralize it, let people come up with the indicators that are meaningful to them, and we won't get any of this gaming, and they'll actually be a true reflection of the activity that's happening out there.
Okay, I'm going to step everyone back a bit, because in a sense I've been pushing the idea of, you know, how do we get to the top, and David said, well, we need to know what we're doing first. Say none of this happens, which is completely feasible, because not much has happened in reality in terms of changing the systemic system. my question to everyone, and I'll step through each of you, is: do you think we can cheat by forcing a better technology platform? And I'm not saying this is an answer. I'm just saying, can we cheat a little bit here? Because if we currently general practice doesn't sit on the cloud. It doesn't talk to hospitals. Hospitals aren't even that advanced compared to other hospital systems in terms of cloud and seamless sharing. So now I'm going to actually go to the question of, horse before cart. Should we start, if we can do anything, we might be able to push common web sharing data standards, and in which case hospitals will be able to move and groove if they want and talk to GPs, and GPs will be able to create. There'll be more secure data from GPs that's better data that'll be able to be used across the system. So start with you, Tracy. Should we start cheating and fast, and how do we do that?
Look, I absolutely think that technology can break through the nexus of some of what we're dealing with.
Yeah.
I also think it can address some of the workforce issues that we've got. That hasn't come up in this conversation so far, but that's the other elephant that we've got in the room. We have this huge deficit of numbers of people that want to work in healthcare. We have these huge retention issues where we've actually trained up enough people, but they don't want to work in our system. Why? Because they find it so frustrating day by day to exist in a system that's not doing the right thing. If I'm not spending hours chasing around trying to find data, that is one less stressor on my workforce here. If I can actually get a better and more accurate picture of what's happening to our patients, that's one less stressor for the people that feel responsible for helping that patient manage their health into the future. Am I a complete technology optimist? No, I'm not. I've certainly seen some systems overseas that have been so technology-led that it's influenced clinical behaviours too much. So we need to choose the right sort of platforms. And I think that's where some standards and some bigger picture design around what the architecture of our IT network needs to look like, so that we're still very personalised about our care, because a lot of IT systems have still been developed based on this is what hospitalists do, this is what primary care does, this is what allied health does. And we need to absolutely cut through those barriers so that, Paresh as nurse practitioner can just get on and do what the patient needs, rather than us having to constantly redo paperwork at cost, at frustration, at time lag, which our system just doesn't have.
David, I'm pretty sure the government's actually talking about funding primary care directly to upgrade. I'm not sure if that's actually going to work. But if you have a better platform, and in the US they forced it, more or less. They forced common sharing standards. So they said provider has to talk to provider, software has to talk to software. If you don't do it, literally you can go to jail. And they gave basis for open API and FHIR standards and stuff like that. Something the government's thinking about. If we move that way and we turned our system over from being a lot of on-prem isolated systems to far more enabled sharing, is that? Do you think that's a step we can take? And we won't need any. We won't necessarily have to have a big leadership from the top and summits and all of this. Is that a practical?
So the strategy we've been following in e-health and digital health for the last 20 years has been a build it and they will come strategy. We've tried to build, and there are plenty of standards out there, but we've left a lot of choice still in the system. But yep. the strategy said, build this set of data and system capabilities and people will come and use it. Well, they haven't.
No.
So the only way to strengthen that approach is to actually go down the path that the US and some other countries have gone down and said, and say, okay, well, we actually have to use some regulation and some funding controls to make people use common standards, etc. And, the fact is we've had billions and billions of dollars spent in digital technologies in healthcare over the last 20 years that still don't talk to each other. New South Wales Health, Queensland Health, Victorian Health, just to take the East Coast, and where you've got, towns straddling borders, etc., they still can't send, you still can't send a piece of data from one of their electronic record systems or patient record pathology systems to the equivalent system in the other state. You have to do it by all sorts of convoluted ways. And yet we've spent billions of dollars. The only way that's going to change is if we say, okay, well, in 5 years, you won't get as much Medicare funding unless you can do that.
Yeah.
Or you won't get PIP funding unless you are able to receive and send.
Yeah.
It's the only way you can strengthen that build it and they will come approach. But as I say, this is where that's still my problem.
Yeah.
Even if we force that approach, even if the data is there, that still doesn't mean that people are going to provide us with integrated care, because that's a different piece of the puzzle.
Yep. Would I be right in suggesting of all these things that they're so hard to get going and do, to bring everyone together in Canberra, or to do this and to do that, this one might be the least threatening and easiest to do on the part of the government, because if they do it, everyone, you get a whole lot of vendors jumping up and down like they did in the US, but you're saying to them, well, you've got 5 years, and we're saying this is 5 years and we're going to help along the way. And if you set that up, and you have a very good framework in a paper you've written, if you set it up, you've at least got a framework for people to argue and engage with now. Might that be the easiest first thing the government could do?
I think it's right up there, yeah.
Okay. Now we're closing, and we're getting to the end, and we try to close on time. So I'm going to give you all 3 minutes. Just going around, starting with you, Kylie, which is the always end of webinar question. If you could pull one lever next week with whoever, what would the lever be with and who? Sorry, although I did.
Look, I do think it's the vision for where we want to be is a really important step. I know it's the big one, but I think it is an enormous system. There are a lot of parts. We need to be moving in the same direction, and we need certainty so that everyone is moving with that certainty of where they're going, and that will address some of those issues around adapting business models, because people will know where we're going.
Okay. Paresh, what do you think?
So, look, thank you.
You get one. You're only getting one lever.
Okay, I'm only going to go with one lever.
Yeah.
So I think technology is best when it brings people together, and so I think the lever we need to use is one that's going to bring people together. So I'm going to go with the data lever, because I think if we've got connected data sets and we've got the ability to use technology to create useful and meaningful insights into what that data is showing us, that will then help us create a learning systems. We use that data and those insights to create a stimulus, which shows us how we're performing, but also helps us do the diagnostics. And that will then hopefully translate into interventions and changes that help us improve the system. So I'm going to go with data, because I think it's critical to a learning system.
Okay, which is the technology thing too. Tracy, what do you think?
Look, I've been working with the Australian Institute of Health and Welfare for years now. So I'm with Paresh. I actually think we need much better data sharing, which, comes back to these standards and interoperability. We actually need some data sets that are real and driven and accepted. And at a macro level, we actually need political data sets. So I look at the experiment that's going on in New Zealand and has been going on in Scandinavia for some years, where at a political level, they're measuring wellness and well-being and vitality and all of those other sorts of things that, whether you're in housing, health, disability, whatever, they all aggregate up into making self-reported health outcomes better and all of that sort of stuff. So we need the bigger political driver, which is not how much money does the Department of Health get, but how are we as a government trying to achieve some of these corporate level community betterment kind of goals. Then we need the likes of the Australian Institute of Health and Welfare, which is the logical government agency, actually empowered to do much better and much vaster data collection, which will only happen if we actually have the decent digital systems to pump the right data to them.
Okay, and David, last word.
Yep. I think we do need to push the accelerator down on things like the data standards and the interoperability standards. But I still warn, all we'll do is drive faster and not necessarily in the right direction. So I'm going to go for number one, along with Kylie.
Vision.
Work out where we want to drive to.
Yeah. Okay. Hey, we're right on time. Thank you everyone who turned up. And thank you to all of the panel for taking the time today. Really interesting. Questions not answered. I think I looked at all the questions and most of them were covered, but if there are not answered questions, we'll get to them. The webinar is going to be posted on AWHA and AHHA and our website. So if you've got peers who and you think this is good for them to look at, please point them to it. And finally, this webinar is a taster for a day that we're going to have on October 18 in Melbourne, a whole day, a summit, where all of this stuff we're going to expand on. If you want to come to that summit, the AHA, I hope is going to just send you a link with a special offer if you attended this webinar. If you want to come, that's going to be a really interesting day. We're trying to nudge and align, so join in. Thanks also to Emma and Kylie for doing so much organisational work here. And we'll see you all, hopefully we'll see everyone at the summit. Thanks very much for joining in.
Thanks, everyone.
See you later. Ta.
Thank you.